Good morning, everyone, and welcome to Cardiology Grand Rounds. I have to apologize. I asked Maribel to print Dr. Eagle's CV in one page, and unfortunately, she had to use a very small font, so I won't be able to read it now because there's a lot of content here. It's a great privilege for me to introduce Dr. Tim Eagle, who I'm sure that he doesn't need an introduction, but nevertheless, I'm going to point out that he's the Albion Walder, Hewlett Professor of Internal Medicine, and the Director of the Frankel Cardiovascular Institute at the University of Michigan Health System. He has an interesting career that started in Oregon, moving to Tufts when he went to medical school, and completing his residency in medicine at Yale University. And his fellowship in cardiology and health services research at Harvard Medical School and the Massachusetts General Hospital, where he actually started his career as a staff. I actually met him at that point at the time where Dr. Fuster was a chief of cardiology at MGH. He moved to University of Michigan, where he actually developed one of the best outcome research programs that focused on quality, cost effectiveness, and practice guidelines. He had contributed with his extramural presentations in more than over 100,000 learners in 33 states and 12 countries. He has published 782 peer-reviewed articles, 77 chapters, and edited 8 books. I think most of you know him as the editor of the ACC website, acc.org. And through my career, I usually, if I need to really get a critical appraisal of the current literature, I actually rely on his writings. He has served in the National Heart and Lung Blood Institute and the HLBI, external advisory committee, and he was as well recognized by the AHA, the next society, receiving the Clinical Educator Award. And he's also the past president of the Association of University Cardiologists. He's going to talk to us about something that is very, very relevant for the clinicians, which is the evaluation of patients who are at potential cardiac risk before cardiac surgery. And that has evolved quite a lot over my career from the time when I met him until now. So I'm really quite excited about listening to your opinion.
Good morning. Can you hear me? Is that good? Okay, great. Well, I'm delighted to be here. I really appreciate seeing friends of mine from the past. You know, I was reflecting last night at dinner, the sorority and fraternity we have in academic cardiology is a lifelong network and community of people that we have the pleasure of interacting with from time to time throughout a life. And every time I come to a place, I learn and try to take lessons that I learned there back to the place I serve. And hopefully sometimes the lessons I offer will give you some ideas or at least insights that might allow your practice to change in a way that you think is positive. So I'm just delighted to have the chance to talk to you today. This talk really is a piece of my mind. I've been thinking about this topic for 40 years, and I will share with you a very interesting journey that hopefully will be funny and somewhat enlightening. There's a typo here. Should be relationships with eligible companies. But if you know of anybody who would like to fund any of my work in preoperative assessment, please let me know. So I'm going to start with a rant. Then we're going to talk about a lesson in history. We'll talk about a lesson in research, a little bit of a personal confession, some things that I wrote that maybe if I could write them again, I might take back or modify. And then lastly, a personal reflection. This is my rant. I don't know if you get this, but I get about 3 of these on my inbox every day. Clear this patient for surgery. Sometimes there's a threat that if I don't do that, the surgery will be canceled because of my ineptitude in clearing the patient. Now, when this notion of clearance first started, I was rebellious. I said, no, I'm not a clearance house. I'm a professional cardiologist. I will help you assess risk. We will talk about whether we think the risk is low enough that the surgery should proceed, or if there are concerns that perhaps we should think about further testing, or for God's sakes, cancel the surgery. But needless to say, that approach did not work. The avalanche of cleared the patient for surgery continued, and finally, I relented. I gave up. But I'm not a clearance house, and I will never be. So pre-op clearance, I don't need that. My doctor tells me I'm the healthiest president in US history. Pre-op clearance is for losers. I don't know who should be preoperatively screened, actually, but we'll talk about how we do that in a cost-effective way. So I want to look back, and if you were in this kayak, you definitely would want to be looking back about what was in your past. So this is the history of sort of modern preoperative assessment. On the left side here, Lee Goldman really started this in the late 70s. He did a study when he was a resident at Mass General of, I think, about 1,000 patients to discern what were the cardiovascular markers of risk for non-cardiac surgery. And they're not surprising, basically signs of heart failure, recent MI, older age, high-risk surgery, aortic surgery, important aortic valve stenosis, and poor general medical condition. And Alan Deskey came along and said, that's too complicated. Let's create a different system, which included the type of operation, age, ectopy, aortic valve, heart failure, angina. Now, I happened to be training at the time that this was going on. I was a fellow in 1983. And I was doing 2 things at once. I was studying nuclear cardiology and epidemiology. And Charlie Boucher wrote the first paper on the value of dipyridamole thallium study before non-cardiac surgery. The focus on vascular surgery, New England Journal. And suddenly, reversibility on a stress test was the holy grail that would allow you to either get cleared for surgery or not. And honest to God, we were actually doing preoperative thalliums on cataract surgery, being referred in mass from the Mass Eye and Ear. And of course, I was studying epidemiology and nuclear imaging, and I thought, this is crazy. It's really more dangerous to walk across the street in Boston than have a cataract taken out. I swear to you. So I was studying that, and I'll talk to you about this journey, but we basically said there are certain markers that should identify a higher risk patient, and you probably should pay attention to those before you decide to do a test. Tom Lee really brought this home with a nice study looking at multiple clinical markers, and this is the revised cardiac risk index that I like to use, and we'll talk about that a little bit more. So chance favors a prepared mind. I was studying how we think about clinical risk, and then we apply testing in certain populations to use the test properly and to not overuse the test. So I proposed to my mentor that we would do a study where we would look at this simple question. Does the patient have a history of angina, MI, heart failure, diabetes, or a Q wave, vascular surgery? And I reasoned that if they had none of those markers, they would not have any events. And in this study, there were 61 patients, 29 were no risk factor. And although 3 of them had reversible ischemia, only 1 of them had post-op angina. There were no events that were heart events. Contrariwise, in patients with markers of risk, if they had a positive stress test, half of them had an ischemic event post-op. Now, I showed this to my mentor, who's an epidemiologist, And he said, you know, Kim, you're not very smart. You developed your model based on a training set, and it's completely biased. I don't believe you. I said, okay, well, I'll do 50 more patients. So did the next 50 patients coming through the lab facing vascular surgery. If he had no markers of risk, even though there was reversibility in 6 of them, there were no events. But if he had markers and a positive stress test, this is where the MIs and deaths were. There were no MIs and deaths here. I took this data to him and said, okay, I did 50 more. He said, I think you should do 1,000. And I said, that's ridiculous. This study is beautiful in its simplicity. I want to submit it, which we did to JAMA. The decision took 2 weeks. Why? Because thallium testing was coursing through the veins of every hospital in this country. What are we doing? What are we doing? So anyway, I did resist my mentor from time to time. It's okay to speak out. So this is how I think about preoperative assessment. We think about clinical markers of risk. What's the patient's functional status in daily life? What's the surgery? And then you get to a branch point where you say, I think the surgery can be cleared, or no, we should think about this. And I think preoperative screening in this context is simple, understandable, and most importantly, you can remember it. So let's talk about the guidelines. The guidelines recommend using the revised cardiac risk index, type of surgery, known ischemic heart disease, prior heart failure, cerebrovascular disease, diabetes, particularly long-term insulin, abnormal renal function. These are the 6 that are part of the RCRI. And if you look at risk and you look at the number of those markers, it is almost a linear relationship with the number of events, okay? And this is not 111 patients. This is 10 million patients studied. So the number of markers of risk correlates with the risk of an overall event very well. So if you think about what we do preoperatively, why are we here? Well, we'd like to find and treat heart failure. We'd like to find and treat important coronary disease, ditto arrhythmias, ditto valve disease, and stable ischemic heart disease. And in high-risk patients, we'd probably like to cancel elective operations. That's why we're here, okay? Functional status is incredibly helpful. I work out an hour a day. I do 10,000 steps a day. I live that motto. If I'm facing a gallbladder operation and I can do 10,000 steps without a problem, I'm going to roll through gallbladder surgery. It's not going to be a problem with Kim Eagle. He'll be fine. Functional status basically gives us a daily account of cardiovascular reserve. And patients who can do vigorous exercise generally have a very low likelihood of a cardiac event post-op, no matter what kind of heart disease they have. This is a study that I found interesting. The question was, can you walk 4 blocks or climb 2 flights of stairs without stopping? And if the patient says, I can't do that, their risk was twice the patients that said they could. How simple is that? Somebody asked Paul Dudley White once in the 1940s, how do you evaluate patients before surgery? And he said, well, my office is in the Bullfinch basement. I walk them up 2 flights of stairs, then down 2 flights of stairs. I take their respiratory rate, their blood pressure, and their heart rate. And I can tell you whether they're going to be high risk or not. How simple is that? But it's true. And you can use the Duke Activity Scale Index. You know, obviously, if you do moderate work in the house, that's 3.5 METs. If you do yard work, that's more, 4.5. Climbing stairs, 5.5. In general, we think that patients who can achieve 4 METs or more routinely without problems, for most part, do pretty well with most non-cardiac surgery. There's no magic number, but this tells you about their reserve, which tells you how they're going to handle both the anesthetic stress and the surgical stress. Obviously, that presupposes that there's not something unusual, like a big bleed or something like that. but functional status is incredibly helpful. So this is something that I want you to take home for sure. So let's call this take-home message number 1. Prior stroke is a very important risk factor for non-cardiac surgery. Prior stroke predicts perioperative MI, okay? So if you look at all-cause mortality, a stroke within 3 months, the hazard rate of that is 3. And 3 to 6 months, it's about 2. So if you have an option, you'd like to wait a year after a stroke before you have elective non-cardiac surgery, but certainly at least 3 months. That's a fact many people don't realize, that stroke predicts cardiac risk of non-cardiac surgery. And the mechanism is actually inflammation, that there is, after an ischemic stroke, there is atherosclerotic inflammation that is present not just in the brain, but also in your heart. Okay, so prior stroke, tuck that one away. Surgery-specific risk is important. And this is a study, again, of 10 million patients. The highest risk surgeries are vascular, thoracic, transplant, solid organ, neurosurgery, and then you get to general surgery, which shows you the risk here. What do you think about carotid endarterectomy? Pretty low risk. Lower extremity bypass is every bit as risky as a AAA. Why? Well, the stress of cross-clamping an aortic aneurysm is large. But the type of patient who comes for lower extremity bypass often has very advanced atherosclerosis. And that is an important thing to recognize. A little fem-pop is a fem-pop. And an amputation is a very high-risk operation because it's in a very high-risk patient. Now, there are other operations that are incredibly low risk. This is an entire year of knee surgery in the United Kingdom. And a total knee mortality was 0.24%. How can Kim Eagle, in a preoperative assessment, lower that risk? No way. I mean, low risk is low risk. So this is the summary then. There are clinical markers of risk, and these we talked about: CAD, heart failure, diabetes, renal, stroke. They all have a hazard rate between 2 and 3. Poor functional status, hazard rate of about 2. Higher risk surgery, hazard rate of about 3. This is simple. This is what I use. And it's steeped in data. Now, if you want to get more complicated, you can. This is a risk calculator from the National Quality Forum, and this has about 20 variables, takes about 5 minutes. I take care of some astrophysicists, and they want to do this, and they want to do it with me. Okay, we'll do that, sure. But it's about the same as the revised cardiac risk index that has 8 variables. Then there's another one that was produced a few years ago called the Cardiovascular Risk Index, which has variations on this. I'm not going to go through it in depth, but it does have support. So what is the most important preoperative test? What is it? The fellows know. It's a history and a physical. It's somebody saying, what's the most stressful thing you do in your life? Oh, you get jaw pain when you do that? That's interesting because you answered no to the chest pain question. No, it's not chest pain, doctor. It's jaw pain. Oh, your idea of sports is watching the NFL? Your idea of vegetables are French fries? Great, we have a problem. We might have a problem. Okay. So, and when we do that, we're trying to find unstable coronary disease, decompensated heart failure, symptomatic arrhythmia, severe valve disease, especially stenotic valve disease. And this is again, looking at the same stuff: ischemic symptoms, New York function, prior MI, especially recent MI is very concerning. Have they been revascularized, and when? And what kind of testing have they had? So heart failure, critical to understand that. Obviously, cardiology has come a long way in defining heart failure. And heart failure with preserved EF is a much different animal than heart failure with reduced EF, than HOCM. So if you get a history of heart failure and you don't figure out what it was, you could do the wrong thing perioperatively. So a patient with heart failure from obstruction, if they get into heart failure post-op and you give them diuretics, they may get worse. Okay? So if you get that history of heart failure, say, well, it's probably, no, you need to know what was the echo, what's the nature of their prior heart failure, especially if they're facing big operations. You must figure that out. Preserved EF hazard rate is about 5. Severe EF hazard rate is about 8. And if they're symptomatic with severe reduced EF, their hazard rate is 10. They definitely have much higher risk. Okay, so let's think about coronary disease. When I was training, we thought that if we could find stable heart disease, ischemic heart disease, and fix it, patients would do better. Okay, that's what we thought. Now, in the preoperative screening era, back then we were doing different types of perfusion and echo. And I just want to show you this study. This looks at the sensitivity of perfusion imaging in patients having vascular surgery for identifying patients who are going to have an event. It's about 85%. That means it misses 1 in 6, right? And stress echo was the same. It misses about 1 in 6. In other words, finding ischemia is helpful, but it's not perfect. It's nowhere near that 95 to 99% number that we typically think about with our testing. And this looks at another factor. What's the positive predictive value? And for thallium testing, if you screened a bunch of patients and they had ischemia, only 1 out of 8 would actually have an event. And for stress echo, it's 20%, only 1 out of 5. So just because a patient has ischemia does not say, oh yeah, they're going to have an event. In fact, most of them don't. The vast majority of them don't. So how do we take these sensitivities and these positive predictive values and put them in context? If a patient can exercise and do that, I think that's the best test because you get ischemia and you also get the threshold at which they get ischemia, which can be helpful. If you're worried about valve disease, then stress echo is probably best. Quantifying muscle, probably nuclear. False positives, echo is probably better. Less false positives with echo. And if you're worried about the LV, either one is reasonable. We don't know for sure about stress CT, stress MR in this context. They're probably useful in some patients. What about coronary CT? Well, we know that the more obstruction you have, the higher the risk. This shows you the hazard ratio with various levels of coronary calcium. But I don't know exactly what to do with this. If I get a calcium score of 2,000, do I do a stress test? If I have a positive stress test, do I do a cath? If there's a lesion, do I fix it? What's the data for that? That's a real rabbit hole. And that rabbit hole is waiting for you every day. So here's your lesson in history. Any of you remember Reverend Bayes? Okay, I'm a dinosaur for sure. Lost all my hair. He's a dinosaur. Reverend Bayes was a reverend by day and a mathematician by night. He was really interested in how you predict events. And his seminal contribution is simple. The likelihood of an event in a population is grounded in their overall risk, then modified by a test result. And if I look at 34 cardiology fellows at Montefiore, they're healthy, they're young, they're low risk. And I better be prepared that the testing I might do would underperform because they're low risk. That's Reverend Bayes for you. This is a study we did of about 1,100 patients having AAA repair. And that they were divided into the low, moderate, and high clinical markers of risk. Here's the lowest group. They all had stress testing. Then they all went to surgery. And this low risk group, 3 patients had events in the low risk. In the moderate risk thallium score, 3. These are 30 patients who had no ischemia, or had a lot of ischemia, I'm sorry, and no events. So in this particular group, whatever the thallium test showed you from low, moderate to high risk, there was no benefit at all. It didn't screen. And you might say, well, thallium doesn't work. And my answer is no, no. Reverend Bay said low risk is low risk. You didn't need the test. All it did was confuse you. They're low risk. Own that and be happy with it. Here's the other side. These are high risk patients. They have 3 or more markers. Their event rate is 18% MI or death. And if they get the stress test, even if it looks good, no ischemia, 1 out of 8 has an MI or dies. If they have a bad looking test, it doubles. These are all high risk. In this particular study, Bayesian reasoning would say that in a moderate risk group, these people had 1 or 2 markers. Their event rate overall was 8% MI or dead. If their test was low risk, it was 3%. If they had a lot of ischemia, it went up 6-fold. Now, there is a range where you might say, you know what? The test is valuable because it moves me from one possibility to another across a clinical threshold where I'm going to react. I may say, you know what? I'm not sure your claudication warrants this kind of a risk. Can we try something else? Okay, so this is Reverend Bayes. His concepts are so important today. Every time we find a new test, we seem to have to relearn this. It drives me mental. So one of the 5 things physicians should do is avoid cardiovascular testing in patients having low risk surgery. We should stop doing so much testing. Do you think this patient needs a pre-op consult? Oh my goodness, that's scary, isn't it? And yet, in the 95 to 2006 era, the number of patients getting preoperative screening consultation for cataract repair doubled. What? You don't need a preoperative test? Golly, really? So another notion I'd like you to think about is what causes perioperative events anyway? And I would submit catechol surges, a prothrombotic environment, blood loss, volume shifts, coronary plaque destabilization, and fixed coronary disease. Of the 6, stress testing can only find this one, right? I don't have a test that will predict plaque rupture, do you? And even the most healthy among you, if you bleed to a hemoglobin of 5, you may have a perioperative MI. So this is important. The catechol shifts happen immediately. Norepinephrine and epi go up. Norepinephrine stays up for a week after vascular surgery. And if you ask the question, okay, Kim, who really has trouble? We wanted to figure out what patients have fatal postoperative MI after non-cardiac surgery. And we were doing a score grant looking at coronary pathology in patients who had death. And we found 42 patients who had careful coronary pathology done after fatal perioperative MI. This is non-cardiac surgery. 20% had left main, 60% triple vessel, most of the rest 2 vessel with Prox LED. Most of them were identifiable pre-op. These are the same patients we're trying to find in our clinic, aren't they? They have advanced disease. And with symptoms, we should probably do something. We will not find all of these patients. These 2 were both women in their 50s, had perioperative fatal anterior MIs after hysterectomy. At that time, we didn't know that Takotsubo was a real thing. These were Takotsubo looking back. This person was 55 years old. His study showed a proximal RCA plaque rupture. He infarcted his RV after a gallbladder attack. We would not have identified that. It was a moderate plaque, less than 50% plaque rupture. We will not find them all. So let's talk about medical therapy. We'll go through the journey of beta blockers, statin, aspirin, clonidine, and hemodynamic evaluation. The beta blocker journey began with this paper by Mangano, which was primarily in vets, San Francisco, looking at potential value of atenolol to lower perioperative event rate. And over the 6 months after surgery, there was a significant decline in perioperative ischemia, and by this point, a significant improvement. This led to the decrease study and elective aortic surgery. They had to have clinical markers of risk. They had to have ischemia. Then they got randomized, beta blocker, placebo. Make sense? And if you were in this study, you definitely wanted to get the beta blocker. There was an 85% risk reduction. Look at that. I remember looking at this paper in the New England Journal, thinking, wow, I have never, ever seen a medication lower any risk by 85%. Jeez. And furthermore, he showed this. You want to go to the heart rate, you want to go to the OR with lower heart rate, 1.3% versus 5. So people looking at that work said, you know what? We must use beta blockers and we must do it fully. I always like to use a new drug before its effectiveness wears off. And Lindenauer was showing in the huge Medicare database that beta blockers in Medicare patients having non-cardiac surgery probably lowered risk a little bit, but probably no more than 10 or 15%. And in fact, he showed this. He said, if you look at beta blockers in Medicare patients, if you have just one marker of risk, diabetes, and you treat diabetics, if you treat 200 of them, you actually cause an event. Oh, if you have cerebral vascular disease as your only marker and you treat 400, you cause an event. Now, if you have multiple markers, okay, yeah, you treat 33, you prevent an MI or death. That's real, but this showed us possibly a dark side. And I was on a committee that was defining whether we would mandate beta blockers in every patient having non-cardiac surgery in this country. And the energy for it was high. We said, wait a minute, that study is a small study, hasn't been validated elsewhere. We need to be very careful about this. Don't do it. If you have multiple markers of risk, maybe. If you have no markers or one, probably harm. One of the first duties of the physician is to educate masses not to take medicine, which led us to POISE. This is the PJ Devereaux study. Looking at the Mangano data, said, you know what? We need to treat these patients aggressively. 8,000 patients randomized to beta blockers before non-cardiac surgery, placebo or beta blocked. Now this group said, you know what? If they need a low heart rate going into surgery, let's give them a low heart rate. Toprol 100 milligrams before surgery. Have you ever started a beta blocker version on 100 milligrams of Toprol? And they're 75 years old, I mean 110 pounds. I remember when he called me to be in this study, he said, I won't do it. I don't know if that's safe. I wouldn't do that study. Now, the endpoint was this one, a combined endpoint, and it favored treatment. It's good that they did a secondary endpoint. They counted the bodies. And guess what? Beta blockers cause more death than placebo. Now that's an endpoint I do care about. And if you looked at why, and here's what would happen. Treat 1,000 patients with a beta blocker like that. You prevent 12 MIs, 6 revascularization, but you cause 13 deaths and 6 strokes. Is that a good bargain? Do you feel good about that? The combined endpoint? No, no. And what was happening? They were having strokes and hypotension and heart attacks because of the beta blocker. Dang. So in patients who have heart failure or recent MI, beta blockers probably are benefit. But we knew that. You know that. Recent MI, yeah, we want to use the beta blocker. Heart failure with low EF, yeah. Even HFpEF, if they have a high heart rate, yeah, we're probably, but not everybody. Please don't do that. Prior MI begets MI. It accelerates atherosclerosis, which is why we wait, because if you have a ruptured plaque, the coronaries are turned on. And there are other plaques that may be vulnerable. You would like to wait for them to be pacified by time before you do non-cardiac surgery. You prefer to wait at least 3 months, 6 months, should be adequate. So I'm going to go through this. So let's talk about lipid-lowering therapy. Linda Nauer showed in a very large study that patients with coronary disease having non-cardiac surgery tend to do better if they're on lipid-lowering therapy. Okay. Well, we knew that. Secondary prevention, the risk reduction with statins is about 1/3. And if perioperative MI is triggered by ischemia and or plaque rupture, you would expect statins might protect. And it does right away. If I take all the fellows to Burger King today, and we eat a huge burger and fries and a great big soda, and we measure forearm resistance within an hour of the meal, it will be altered by the meal. And if I give you all 80 of Lipitor tonight, and we go back and do that experiment tomorrow, your forearm resistance has changed from 1 dose of statin. Okay? Oh, so it's not just the LDL, is it? No. How fast does it work? Last night. Statins affect the vascular biology. So they're helpful in patients who have merit for them. The DECREASE-3 study suggested this weak statin had a 50% risk reduction for MI death in vascular surgery. And also, the combined beta blocker statin did way better than either one alone. Holy cow. Once again, people are looking at this data saying, too good to believe. And it was. This is your lesson in research fraud. And in my life, I have never seen a field so affected by research fraud as this. As people started looking at Polderman's reports, increasingly they said, that's too good to believe. And they were right. And in fact, his university commissioned a committee to review all of the data underpinning his important clinical trials. And what they did was to find negligent and scientifically incorrect information. And they looked at the various studies. This first one, which was published in New England, didn't get investigated. It was too old. This one, looking at stress testing, said there was a fictitious method of establishing the outcome. This one, no source data to investigate, only witnesses. This one said, well, the events didn't actually match what was in the hospital record. This one showed a falsified method of risk profile assessment. And this one showed that 97% actually didn't have the stress echo at all. For those of us who do research, those of us who mentor people doing research, this experience is very sobering. And we must always question the methods, look at the data. When you see something that looks too good to believe, sometimes it is too good to believe. And I'll occasionally get a paper to review and I'll look at it and I say, you know what? It doesn't make sense to me biologically. It doesn't seem plausible. I just, without the source data, I'm not sure I can say, yeah, I'm not sure. It's okay to question. So statins, looking at large groups of patients having vascular surgery, they lower risk. They are definitely to be used, right? And we'll go by this in the interest of time. POISE 2 looked at aspirin. We get this all the time. Does a little aspirin before surgery prevent plaque rupture and thrombosis? Well, probably not. This is a big study, 10,000 patients. No effect of aspirin on mortality or MI, but there is bleeding if you give aspirin. Okay. The only part of this that has a caveat was that in POISE, there were patients who'd had a prior angioplasty, and they seemed to get potential benefit from aspirin. So it's probably true that a recent stent, patients probably should be on an aspirin, and we'll talk about the timing of that. This is another large study recently released, again, looking at aspirin and basically no benefit on death. And there is bleeding if you give aspirin. So a little aspirin before non-cardiac surgery can cause a lot of bleeding. And we shouldn't invent a reason for it if there's not a firm reason already there, particularly stroke, heart attack. Clonidine, you know, when I was growing up, we had a lot of observational studies showing that clonidine seemed to lower perioperative risk. And so the POISE investigators studied 10,000 patients, and there was no effect on mortality at all, but there was hypotension from the drug and bradycardia. Once again, the drug failed the test of a clinical trial. What about a Swan-Ganz catheter? You know, it's interesting. PA lines have never lowered mortality. We're talking, it's a test. It's not a therapy. Of course, it doesn't lower mortality, but does the knowledge you get from a PA line lower mortality? I don't know. This is a randomized trial, beautiful study, 750 patients having big surgery, randomizing patients to get a PA line or not, and there was no effect on mortality. There were a few pulmonary emboli if you got a PA line. Basically, a PA line can be useful for helping you understand hemodynamic status in an uncertain moment. My belief is if we need a right heart cath, let's get a right heart cath. Obviously, this is not true sometimes in a tough ICU patient, but the notion of a PA line lowering mortality for big operations is a myth. It doesn't. Proven in a large trial. So what about prior coronary revascularization? Now we really get into it with Kim Eagle, okay? We really get into it. And this is my confession. I grew up in an era when we started angioplasty, and we were rocking. We were fixing coronary disease, and it was a feel-good moment. Your plumbing is bad, we can fix it. And we will, and look at that picture. Damn, that's great. Well, I don't know. I published this study in Circulation, which basically looked at CAS registry. And it asked the question, if you were getting a non-cardiac operation in the CAS registry and you'd had a prior bypass versus medical treatment, did the bypass group do better? The answer is yeah, a heck of a lot better. They had a 50% reduction in death and 2/3 reduction in heart attack. And of course, there was a little paragraph maybe in the discussion that said, of course, to get the benefit of the downstream cabbage, you have to survive it. A little caveat, Kim. Okay. Yeah, you're right. It's not randomized, is it? You could be biased. What about immediate revascularization? This was studied, and I love the fly fish. So any study named after a fish, I'm going to love. So the carp is the coronary revascularization prophylaxis trial. And this is veterans who had coronary disease. They were being screened before vascular surgery. They had to have stable ischemic heart disease. And it led to a study group of about 500. They excluded the left mains and the severe EF group. And they randomized them to getting their coronaries fixed or not before elective vascular surgery. This is really a test. If you have a little angina and you're facing a FEMPA or AAA, does fixing your coronaries before it help you get better? Are you better? So the EFs were good. They included the lowest group. A third of them had high risk disease, 3 vessel. Here's their indications. And they had disease, angina, MI, heart failure. They had a lot of disease. And a lot of them were on beta blockers. A lot of them were on statins. And there was no event reduction by revascularization. None whatsoever. And you might say, yeah, but the revascularization is improving 5-year outcomes. Well, that wasn't affected at all. At 5 years, the event-free survival is the same. Have courage. Excellent medical therapy for stable ischemic heart disease is excellent. And patients get through vascular surgery in that scenario just fine without fixing their heart. Okay? So the journey I've been on has seen these drugs come and go. Beta blockers, potential harm, no benefit, no benefit, no benefit, no benefit. Statins probably work. Holy cow. I spent 40 years of my life. This is a piece of my mind. I'm coming all the way back to you. I'm at your bedside. I want to know how you are. Tell me how you are. What happens when you exercise? What happens when you're upset? Have you ever had a problem? So how long should we wait after a stent before we allow patients to have non-cardiac surgery? The old data, bare metal stents, suggested that we might want to wait as long as a year. The newer drug-eluting stents say, you reach a plateau by at least 6 months. And more recent data suggests even shorter. And if you ask the question, patients who have major cardiac events after having a coronary stent, the things that predict risk are emergent surgery, recent MI, high risk index, not the type of stent, not if you stopped antiplatelets, and nothing in patients who were stented more than 6 months ago. No effect at all. So 6 months is a reasonable time. If you need to do it sooner, I think most patients probably will do fine. And I'm going to go by this just in the interest of time. And the amount of time we stop antiplatelets before surgery, of course, varies with the type of antiplatelet drug. A couple other caveats that I think are interesting. What about SGLT2 inhibitors? This is often not appreciated. As you know, these can cause ketoacidosis perioperatively. So we should stop these drugs before elective non-cardiac surgery. And you, the cardiologist, need to know that. There's another interesting caveat, and that's these new agents that we use a lot, GLP-1s. These slow stomach emptying. So in a patient who's taken one of these recently, there is some momentum to say you might do a gastric ultrasound to see if the stomach is full or not before you do a big operation on this patient. It's at least a thought to consider. As new agents come along, we have to imagine, okay, what does the relevance of that drug have to my preoperative moment? So I think let's go by this. Who should I screen then? Very high-risk surgery patients who have multiple markers and poor function. If you came to me and said, listen, I want to climb Mount Kilimanjaro, and I've had an MI and some heart failure, and I'm pretty sedentary. You might say, before you climb to 20,000 feet, we might do a stress test to see what your reserve's like and make sure your heart doesn't have nasty disease. That's the group that we want to find. They typically have evident disease. They might be facing a big stress, and you'll have no idea what their reserve is because they don't do much, right? That's that stuff. Clinical markers, functional capacity, type of surgery. It's simple if we let it be simple. Now, what about surveillance with postoperative EKGs? Probably you should do EKGs in high-risk patients immediately before and for a day or two after. That's probably reasonable. And measure troponins if there's a reason. Oh my God. Now we're really going to get into it. With troponin, what about biomarkers? God, we can measure so many things. Reverend Bay says, be careful. Be careful. So, for example, we know that high sensitivity troponin is associated with risk. If you have a low level, the mortality is low, but if you have a high level, preoperatively, you have higher risk. Oh, that's interesting. And if we look at other biomarkers, they have some evident risk. Biomarkers predict outcome. Revised cardiac risk index, elevated natriuretic peptide, hazard rate of 2. Oh, so should I do a cath if they have a high BNP pre-op? What do I do with a healthy looking patient who has a high sensitivity troponin facing non-cardiac surgery, or BNP for that matter? Pick the test. Do you think we know how to adjust treatment in stable patients with elevated biomarkers? I don't. I have no idea. And I have learned Bayes' theorem. I've lived it, so I'm not going down that rabbit hole again. And interesting, cardiology fellows know this. The higher the troponin in the hospital, the more likely they are to be called. If you go to the finish line of the Boston Marathon, 12% of those patients describe shortness of breath and have an elevated troponin. Do they need a stress test? They just ran 24 miles. I mean, what? I love this quote by Bob Jesse. He said, when troponin was a lousy assay, it was really a great test. But now that it's a great assay, it's a lousy test. God bless him. He was head of the VA cardiology for years. He passed a few years ago. Wonderful man. So a personal reflection, less is more. Here's a hypothetical. Let's assume we're going to create a human laboratory to study perioperative plaque rupture and risk. Okay? We're going to take stable patients. We're going to balloon or stent a stable coronary plaque. And then we're going to do something to them. We're going to bleed them. We're going to give them pain, sedate them, sleep deprive them, and give them a bunch of Ringer's lactate. Cool. Okay, so when I went to the University of Michigan in 1994, I had shared the national guideline on perioperative assessment and evaluation, in which we said, let's use Bayes' theorem and not test everybody who's going to have vascular surgery for coronary disease. And at the University of Michigan at that time, if you were getting a AAA, 88% were getting a stress test, a quarter were getting a cath, a quarter were being revascularized before elective AAA. I rolled into town. I said, you know what, let's just follow the guidelines. And our testing dropped in half. Revasc went from 24% to 2%. And in the next year, these are AAAs, the event rate or the numbers were similarly small. We stopped doing testing on stable patients because studies have shown and a guideline suggested we didn't need to do that. Now, some of my colleagues, particularly in anesthesia, said, Kim, you're killing people. You're absolutely killing people. They're going to surgery with coronaries that had not been fixed. I said, no, we're not. We're not. And if you look at outcomes, the combined MI death rate went down, almost statistically meaningful. We were taking stable plaques and rupturing them and then doing vascular surgery. I'm convinced we were causing MIs. I'm convinced of it. What are you thinking? Come on. Oh my God. Okay, prediction is very difficult, especially about the future. This guy got a Nobel Prize. He's right. The future will be better tomorrow. I hope that's true. I don't know. This one I love. This is your former president. Flight on Air Force One is $1 million, suit 6,000, bulletproof vest 6,000, and your commander-in-chief looking at his troops with the lens caps on. That is not what you want to do. And we can't get blinded in the perioperative moment and do things that don't make sense. It happens a lot, and it's not necessary. Osler said it best, medicine is an art of uncertainty, a science of probability. I'd always like to acknowledge the fact that I would never be here, have the professional life I've had without many people, many mentors. And there's a whole list of them here who I consider to be really my medical fathers. They taught me my craft, and I owe everything to them. And, you know, my family, my parents, et cetera, and colleagues like you. We are today a collection of experiences, educational and interactive, throughout our professional life. And I'm a different doctor today than I was yesterday because of lessons I learned last night at dinner from colleagues that you have. And that is a wonderful thing, that we can be in an environment where our fellows teach us, hopefully we teach them a little bit, and we learn together. It's magical. So thank you very much. It's been a pleasure.
Thank you so much. That was a wonderful lecture. We really appreciate your time being here, and the dinner last night was a lot of fun as well. So we'll start with a question here for people here, and for the ones online, please put your questions in the Q&A so we can see them. So Dr. Garcia, would you like to start?
So we'll be proud to know that we have so far able to fence the introduction of high sensitivity troponin. We can't do it for much longer because we've been told that the equipment to analyze the standard troponin is being discontinued. So we're gonna have
I'm
to.
so proud of you, but eventually the wave will roll over you and then you'll have to deal with it.
Yeah, we're gonna have to triple the size of our fellowships.
Yeah, exactly. Yeah.
Uh,
I think the fellows should have a T-shirt, Troponin Fighters or something like that.
I have to challenge you on one issue, which is the value of the medical history. Many years ago, we looked at our database of cardiopulmonary stress testing. And we look at how our esteemed heart failure cardiologists have rated functional capacity on individuals before they went and had the testing. And I have to say, our colleagues in heart failure are, or at least they think they are the smartest ones in the faculty. And clearly, if they say that they were functional class 4, functional capacity measured objectively was truly low. But if they say functional class 2 or class 1, some of them were exceptional, some of them were as low as the functional class 4. So when that old lady tells me that she can walk the 4 blocks or go the 2 flights of stairs, how much can I trust her?
We'd like to repeat your question.
Yeah, so the question is, how good is the history for really giving you a functional assessment? And my answer to that, first of all, I agree with you that quantitating the facts we get from patients and families can be hard. But for the purposes of preoperative screening, I believe we can get enough by asking what they do. Okay. I take care of an elderly Italian woman, and she doesn't exercise much, but she spends 8 hours a day on her feet in the Italian restaurant helping her sons deliver the food to the tables. I'm not going to screen her before non-cardiac surgery. I know that she has good capacity. So I use that a lot. Tell me what you do. And then the patients who say, oh, I have no problem, but then they say, well, yeah, I've given up vacuuming because my kids do that for me. And I don't grocery shop anymore because that's not necessary. I worry, even if they say I'm fine, that they've stopped doing things in daily life that demand some level of capacity, and they may not have a reserve, and they may be hiding things from me. So I respect your opinion. And the heart failure docs are the smartest, for sure. There's no doubt about it.
Thank you so much. That was wonderful. So we have a question here from the chat from Luis that is actually the same thing that I was going to ask. We talked about revascularization before surgery, but what about patients that will undergo transplant? Can we extrapolate the findings that you commented on?
Yeah, I'm glad somebody asked this question. And renal, lung, liver transplant patients are all, we wrestle with them all the time. And the variation in what different centers do is all over the map. Some centers are going to insist on a coronary angiogram before they do a liver. Other places are going to say, you know what, I think that I can get by with a good history and physical and maybe a stress echo. This is a real interesting and challenging conflict, whereas you have a limited number of organs. And so if you had to choose, you would prefer to put those in patients with lower risk. But Mario's dealing with one patient in front of him with stable coronary disease saying, I want a liver. And should stable 3-vessel disease mean I can't get it? And there is the challenge. We do dobutamine echo and say, you know what, we think that's good enough for finding the kind of nasty disease that really might limit a lifespan or the perioperative stress. But I admit that there's a lot of variation out there.
Thank you very much. And following that question, we talked about doing stress testing only in the highest risk patients. But is that going to change our management? Should we revascularize the ones that come with an abnormal test?
Yeah, so that's I would say to you that when we find a high-risk patient facing major surgery and they have let's say they have poor functional capacity, they've got multi-vessel disease. If they end up fitting into a group where anatomically we think there is survival advantage for revascularization, I do it. I do it. That's left main for sure. That's triple vessel, especially with poor LV function and or a lot of angina. If they have good LV function and minimal symptoms and 2-vessel disease, I'm not at all convinced revascularization lowers their risk, and I manage them medically, perioperatively, and for all time, unless something changes. There are certain high-risk anatomies where we still hold the notion that if we find them and they have anatomic indication for revascularization for survival, then of course you would do that before they climb Mount Kilimanjaro. You're going to do it, right? But it's a very small fraction. You know, out of 100 consults, it's 1 or 2. It's not 30 at all. Okay.
Thank you very much. And just to close, any comments on severe aortic stenosis, TAVR versus balloon?
Yeah, it's a great question. Obviously, if we see a patient with symptomatic aortic stenosis and they go through non-cardiac surgery without having their valve fixed, their mortality is 10%. This came from a large study from Mayo Clinic, patients who actually were offered a valve therapy and refused and went in, got fixed. So if I have a patient who comes to the ER with a hip fracture and clinically significant aortic stenosis, and the surgeon says, you know, if we don't fix the hip, she's not going to walk. I say, okay, bite the bullet, we're going to do it. Obviously, if you can fix the valve and it's more elective in nature, doing a plain old balloon valvuloplasty imposes significant vascular risk without a long-term benefit. So if you get that patient a TAVR and then delay the non-cardiac surgery, that would make sense. If the surgeon says, no, 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 this patient is bleeding from a colon cancer and we have to get it out, then you're faced with, well, do I let him go with a valve that's tight, or I do a valvuloplasty as a temporizing measure? And that's really a doctor, patient, family discussion about the risk of the valvuloplasty versus not doing it. Okay.
Thank you very much. Well, we really enjoyed the lecture, your company here, and now we have some time for you with the fellows. Thank you so much.
Great. Thank you.